Many of you who attended the BTS in Belfast hopefully saw the Commonwealth Tribute to Life presentations, and that was a project that was officially aligned with the 2022 Birmingham Commonwealth Games. It's an official project that's aligned with the Games, and it was designed to try and encourage sharing of knowledge and expertise amongst the Commonwealth countries. A total of 43 Commonwealth countries signed a Memorandum of Understanding, and that was also signed by 19 organisations nationally and internationally. And the aim of that Memorandum of Understanding was to try and share awareness, increase organ donation rates, and to share expertise. Now, that expertise that we can share is a two-way interaction. So some countries, such as Australia, UK and Canada, can share their policies, their pathways for a very well-developed organ donation system. But there's also much that we can learn from other countries where perhaps their organ donation systems are not quite as well developed. So, for example, we've heard earlier this morning in the NHSBT session about the reduced organ donation rates and consent rates that we get in our ethnic minority communities, for example. And many of our ethnic minority individuals in the UK originate from countries from across the Commonwealth. So there's something that we can learn from our colleagues in these Commonwealth countries with regards to how we interact, how we speak, and how we can try and improve rates. So, without further ado, I would like to introduce our very first speaker, and our first speaker is Cathy Miller, who works for NHSBT, and as part of her PhD research, she was involved in looking at how to introduce the legislation and implementation of deemed consent. Cathy, over to you.
Thank you, Adnan. Thank you, everybody, for having me here today. It's a real privilege and opportunity to present my research findings. These are interim research findings, so I would really value any questions that you may have at the very end. I'd like to begin by acknowledging the team under study, which was the West Midlands region, and I'd really like to thank them for their professionalism and their enthusiasm, because without them, none of these findings, albeit interim, would be possible. So thank you very much. The purpose of the research was to evaluate the implementation of the deemed consent legislation regards the education and training programme that was provided, and that was for nurses covering England. The research approach I've taken is a longitudinal approach using a desk and a field-based approach. So the desk-based approach is complete, and that involved a comprehensive literature review, temperature checks, training needs analysis to inform the training approach, and all of the modules were evaluated. The following part was a field-based approach, which had many elements that you can see there, looking at analysis of digital training footage, and what I'm going to talk to you today about is the participant observations. They were the most useful part of the research, and that's what I'm able to share with you really in the next 15 minutes. All of the nurses under study were offered and took part in the opportunity to do a semi-structured interview, and all nurses observed took part in a debrief, which was equally informative. So the sample size was 28 specialist nurses, and the participant observation took place on 13 occasions, 10 of which proceeded to formal deemed approaches. These are the tools on the screen that were used. So there was a participant observation tool, which is a proforma developed to record what I observed in the room between the specialist nurse and the potential donor family and the clinical staff. We debriefed that tool afterwards, straight away, and the research interviews took place at a later date, and most of those were virtual. So what I found in terms of planning and approach, on the whole, best practice guidance was followed, and the best practice guidance I refer to as the NICE guidance in 2016, where a planned and collaborative approach was advocated to the family for organ donation between the intensive care team and the specialist nurses in organ donation. On one occasion, the consultant had a decoupled approach in that he talked about breaking bad news, and the SR went in later to talk about donation, and a planning conversation didn't take place on one occasion. On 2 occasions, including the one I've just mentioned, the consultant was unable to take part in the approach because he was attending to a paediatric on an adult intensive care during COVID. So to mention that as well, this is a complex evaluation. The law change is complex, but introducing it during the time of COVID into already a complex healthcare system made that even more tricky. So in terms of the context of the deemed approaches, what I noticed was a real resilience in the specialist nurses. So this particular case I talk about here was a death, sadly by suicide, of a young man with 3 young children. And the specialist requester here was involved in an incident where armed police were involved prior to her ever getting to the intensive care unit. And when she arrived on the unit, she said to me that you won't believe the journey I've had here. And I took that to mean the traffic. But later on, afterwards, we had a debrief. But what I want to draw out more importantly here was her ability to park that and carry on. And this case proceeded. What this SR did really well as well was empower the family. So there were young children in this family, 3 young children under the age of 5. The bedside nurse was pregnant and had 2 children of her own and was very paternalistic about any children coming to the intensive care unit, and she was able to empower the family to make an informed choice, and 2 out of the 3 children did come to the intensive care unit. She was very inclusive and holistic in her approach, involving the family members. And to note here, which I'll talk about later, the mum was a nurse and other relatives were healthcare professionals. This case proceeded. The choices of language were around the law of the land. Now, this wasn't something that was taught in training, but what it demonstrated was that this SR was working at an even higher level. Through her experience, she could take what she was taught and make it her own, which was absolutely fabulous. And although that term might seem a bit harsh in black and white, actually it wasn't. It was a really well-toned conversation. In terms of language around donation, in some of the DCD, donation after circulatory death conversations I observed, the language could be quite conflicting in saying things like it'll be kinder to let him go, and kinder to let him go, not to put him through the mill, that kind of language. I noticed a difference between donation after brain death conversations compared to donation after circulatory death conversations. And this is just an example of some of the language used around he hasn't opted out, so would suggest he has no objection, and a decision that they have to support that is right for them as a whole family. In this case here that proceeded to donation, what the SR did on this occasion was really leverage the legislation. I observed a very confident planning of approach conversation with the clinical lead for organ donation, and to note in my observations where the specialist nurse or requester was working with a clinical lead in organ donation, there was a very seamless transition into the conversation. With all the approaches though, there were very two-way conversations between the healthcare professionals. This approach was done outdoors in the garden because of COVID and social distancing. The family were very accepting of the death, but very guarded in terms of they did not want, their husband did not want his partner to be butchered or in a debilitated state. And what the SR did here really well was navigate that conversation, answer those concerns, discuss them, open and talk about them. But then what she really did really well, when they said they didn't know what she would have wanted, she was able to talk about the law change. And she actually empowered the family to go away and talk to the brothers. And she termed their conversation might muddy the waters because those brothers weren't privy to this conversation. So she not only talked and supported the family in front of her, she helped that family and empowered them to talk to other family members and gave them the words to say, to explain it. Her language choices when the family said, I don't know, she said, what we do know is that she hadn't opted out or signed up to the organ donor register, and what the situation in England was, and how the decision was already made by not making an objection to avoid burdening family members. In one of the unsupported deemed cases, what I noted was still good practice, despite the decision not to support donation, is where the nurses would have an initial eyeball on the patient or early contact with the family on the unit, with the unit staff and supporting them and accessing medical records. This SR as well jotted down names in a notebook, and I noted the SRs, or the people that were out more frequently, that was a strategy that worked well, so that they were talking to the right people at the right time and they'd got their name. They were doing their background work. Very good planning conversation again, and ability to explore and encourage an informed outcome. And what the SR said in this instance was that we can assume deemed consent because we do things in line with other countries. We can assume deemed consent. The mother did want clarity on this occasion, and this did not go ahead, this case, but it wasn't without a real deep exploration. And that exploration was around the partner having real concerns that she would be like a jigsaw, and he didn't want a jigsaw. He wanted a whole pieces. He wanted a whole jigsaw. And he went on to talk about, could she have a brain transplant? And what the SR did on this occasion was really pick up on that visual and metaphoric language and tune into it. And she flipped the conversation. And she said, if he could be saved by a liver transplant, would you want another family to say yes to organ donation? And he still remained adamant that it was one piece and whole that he was worried about, along with the mother. But what I really seen here was the ability to explore, and this family went away with a really informed decision. There was no ambiguity. They did not want to donate, and she was able to do that without causing any stress or concern to the family. It was a really honest, open discussion. This case here, the legislation wasn't mentioned in this unsupported deemed case. There was a really good planning conversation between the SNAD and the CLARD and the bedside nurse. It was a large family, a family from the Muslim population, and the SNAD on this occasion really looked up information about Islam. She brought an imam to the unit. She got very well prepared. She built a brilliant rapport with the family. They were a large family. She was of a large family, and she made that connection. She talked about their loved one and how she loved to hoover, and she was sassy, and those kind of words made a real connection with the family. They were well able to park the what happens next part of the conversation. When we arrived on the unit, this family had already gone to bereavement. They were accepting of the death, so much so they wanted the medical certificate of the cause of death pinned onto the observation chart. They were really accepting of death and wanted a real quick burial, and there was no way that donation was happening. Despite the abrupt no, is how I would describe it, and the response of it goes against our religion. If you take organs out of a body, they don't go whole to God. The SNAD did try and explore that strong objection and asked quite humbly, what does it say in your religion about helping others through organ donation? And the brother responded, we just don't want it. The benefits of organ donation nor deemed consent legislation weren't discussed. And during the debrief, when we talked about that, it was to avoid any inflammatory responses. In this case here of an express known decision, the partner and the daughter were conflicting regards the response here for this lady that had died. The partner, the husband, felt, yes, I could do that, we could go with that, but the daughter said, no, we've had a conversation, Mum wanted to be buried whole. And I think what I've seen with the express known decisions is a sense of drawing the line. I think every SNAD or SR that I observed, including myself, had a line that could be drawn. And that line was, how far do you explore and how far do you probe a conversation with a family that are grieving in front of you? And I think what was clear is that people's lines were different. people's lines were different with different families and different SRs or SNODs or myself. On one occasion, I was uncomfortable out of all of them, but not uncomfortable to the point that the SR was doing anything wrong. The point that I knew my line had appeared before hers, she was able to explore more than I think I would have in that given situation, but only once. But I think in the cases of the express known decisions, a couple of those perhaps maybe could be explored a little more. But the more I've looked into this and what the codes of practice say, the more I'm realising or beginning to discover that the codes of practice have a real clear guidance for us, a legislation, a regulation in black and white. What's not so clear is the context that we're out there facing and how we can apply the codes of practice in that real situation. So in this other express known decision here, this was a donation after circulatory case again, where the SNOD fella thrown into the conversation a little bit and felt that the family were clutching at straws, and she perhaps on hindsight wouldn't have gone ahead with the approach as quickly as she felt she should have. And some of the language around putting through the mill didn't fully help that conversation with that family, but they felt they didn't want to donate because the man himself that had died was in a similar position when his own dad died, and he didn't want to be a donor. So that was that case. And this case, oh, that's the same case, sorry, yeah. So this case was a new SNOD, new to the rota, hadn't been out, volunteered herself to do an SR shift to get experience, and she built a great rapport with the family. The family's name had lapsed out of her mind, the mum that had died, so she referred to her as the mother. She built a brilliant rapport up. But interestingly, when we reviewed the digital footage and training, a couple of people had forgot the potential donor's name, the family's name, and would joke and say, oh, but you wouldn't do that in real life. But actually, it can happen. You can go blank in real life. And the strategy that I'd seen an SR use of jotting the names down could be quite helpful for that, particularly if you get nervous or you're out approaching different families. Okay, so some of the language choices by that specialist nurse that built up a fantastic rapport with the family were how, unfortunately, we're unable to save your mother, but through the donation, she could save the lives of others. The daughter in this case said when she signed up to the ODR, her mum was frowned upon it. And when that was explored, they said that it was a spiritual belief of her mother's. In terms of recommendations, this is the framework that's recommended for having the conversation. So it's only a framework to hang the conversation on, particularly for new specialist nurses coming in or people that haven't been out. And it's taken from the training, from the learning, and that's the framework that's suggested, that you have some important information to talk through with the family, that they are in a very special position to donate organs for life-saving transplants and to help the lives of others through kidney transplantation, for example, and how the way organ donation works in this country is to enable more people to save more lives, and that we've checked the organ donor register and they haven't opted out, which means that they are considered willing to help save the lives of others. I'll give you some more information to help you process all of this. And the last bit there talks about having any sense of whether organ donation or whether they had any end-of-life care discussions, and using the word, do you have any sense whether or not they have. That is to establish the last known decision, because one of the things I've noted in the responses from the survey questionnaire that went out to the whole workforce was the express known decision. The finding out about that comes quite high up in the conversation. And what people feel when that happens sometimes is they get a gut instinct, like a knee-jerk reaction from the family, that they don't want donation. But sometimes that can be a knee-jerk instant response to grief as opposed to them not wanting donation. So what we really want is the family to make an informed decision or choice based on information. And if they don't have the information, then that's quite hard to make an informed decision. So families appear to have polarised views, yes, no, or they might be sitting on the fence. Where they're sitting on the fence, the legislation can be leveraged, but if the family really wanted to donate anyway, they were always going to donate. So the legislation may not be a lever in that case. And if the family really didn't want to donate, it's really hard then to bring the legislation in later to try and influence or change that decision. So for those families that didn't really know what they would have wanted, the law can be leveraged and was leveraged in my observations. Families that are connected in some way to transplantation or are nurses or know of people in the healthcare profession, 3 out of the 4 were in the cases that preceded, and the 4th was a telephone consent whereby the brother knew that the law had changed and said, oh yeah, everybody's doing it now, aren't they? Everybody's in now, aren't they? So that was his understanding. If there is no ODR registration in deemed cases, it does create an uncertainty for some families. And the information digital link could be a tool that could be used potentially. So somebody that's not on the ODR can be a tool for deemed consent, the little video to show the family. I think I've come to the conclusion. It's the small percentage of the law and a far larger percentage of hearts and minds. And that planning and collaboration is very good. And that the uniform that the SNODs wear really does help integrate them as part of the team. So just coming towards the end now of the presentation for me, consent is a very contextualised process. So it is a process. It isn't a one-stop shop at the formal approach. It really was, prior to somebody even getting to the unit, having a traumatic experience, to really being present and having a presence on the unit and really being supportive to the staff, to the family. It starts very early on. And for me, the observations were the most important part because having done the job, I'd be remembering it from when I did it, whereas I was able to go out now during COVID and really see what the context was like. And actually in all of those 13 cases, my experiences weren't comparable to any of those cases. There was similarities, but they were all very unique. And that's what this has taught me, that each SNOD and SR is unique, each family you meet is unique, each consultant, nurse, you're never going to get the same situation. And what was really evident in all of those nurses that I observed, there was early contact, they were well able to build rapport, create trust, have a present, really listen, really actively listen, and were agile and responsive to the family's needs, whatever they may be, and were well able to navigate the conversation. They were holistic and inclusive, talking about people that weren't even in front of them, that were at home, that they could signpost them to other services, and really empowered conversations for other family members. And end-of-life care had certainly moved on in terms of, yes, handprints, locks of hair. But I seen scans of hearts being done to create a heartbeat on a phone to go in a daughter's locket for a wedding. There was real amazing things out there that the specialist nurses and requesters were doing. So the final point is about the contextuality, is how complex it is to evaluate whether or not the training worked, because it's multifactorial. And what I know is all of the nurses know the inclusion, exclusion criteria, deemed consent upside down and inside out. What is more difficult to measure is the difference it makes in terms of the legislation being brought in during COVID, families' awareness. There's a lot of myths and misconceptions that the nurses were uncovering and addressing and able to do that. So certainly the theory is there. The actual eventualities of each case is very much unique and individualised in the current context. Thank you for your time and the opportunity to present the research today.
Cathy, thank you very much.
Mm-hmm. Thank you.
So we're going to take questions for everything that you're about to see for the rest of the session at the very end. So please do put any questions that have come to mind for Cathy or for anybody else into the app, and Adnan is moderating and we'll get through that. So we're going to focus on kind of the Commonwealth. We're going to be introducing some colleagues from around the Commonwealth, and also Julie is here on stage with me today. But first of all, as it's a landmark day in one of our Commonwealth member nations, I do have to say, don't laugh, you Welsh speakers. Dydd Gwyl, Dewi Hapus in Ffrindiau Cymraeg. Happy St David's Day, thank you. Thank you. Happy St David's Day, 1st of March. So, what we're going to do now is a panel discussion. Now, it is a well-trodden path that we have looked at in the past around opt-in versus opt-out and the comparisons that we might look at there, or we might look at brain death, or how that's implemented in every country, or even the approach model. But we're not going to do that today. Actually, what we've seen this morning from our statistics colleagues around the lack of consent in Black and Asian groups, and as Adnan had pointed out as well, we want to actually look at a cultural comparison, how we, as a predominantly white organisation, approach families from different cultures and what we can learn from our colleagues around the world. And so hopefully we're going to see some colleagues on screen from India, Singapore and South Africa. Hello, can you hear us?
Hi, Phil. Hi.
Great, great. This is really good news. So our high-tech work is on point to start with. Our panelists are going to introduce themselves in a moment, and having just said that well-trodden path that we're going to try and avoid, we are going to avoid, I think we do have to have, as part of our introduction, a bit of an understanding really about whether our colleagues work in an opt-in, opt-out environment, whether they are part of a collaborative approach or whatever else. So I'm going to ask Julie to start us off, and then we're just going to hear who you are and the environment you work in, and then I will come to our Commonwealth colleagues. Pallavi, I'll start with you after Julie. Go ahead.
Thanks, Phil. So I am Julie Booth. I'm one of the specialist nurses here in Scotland, and we in the UK work in a soft opt-out system that was introduced in 2021. And ideally, our model that we use the most is a planned collaboration when we're discussing breaking bad news and the donation conversation. So generally that will involve a consultant or a doctor from the hospital, the bedside nurse, and us as a specialist nurse there to talk about organ donation as well.
Perfect, thank you very much. So Pallavi, let's come to you then. Just follow Julie's lead on that one.
So I'm Pallavi, and I represent a not-for-profit organization called the Mohan Foundation in India. We are a 25-year-old organization. We have been involved in training what are called transplant coordinators. So unlike UK, they're not called transplants, they're called the transplant coordinators. And we've been training transplant coordinators since the last almost 12, 13 years. And most of the coordinators that are working across hospitals in India have undergone training by us, so we understand them, or we understand that process that they follow. We are primarily an opt-in country. We are very far away from any conversations around opt-out as yet. You want me to talk about the approach right away, Phil?
Well, just the model of your approach. Do you go collaborative, or is it something different?
So, we are trying to put those defined methods in place. There is still no one single way of doing it, but in our training, we are very strongly advocating the combined approach that NHSBT does. We have a formal MOU with NHSBT, and there has been a lot of learning from you. In fact, we took a training film and we recreated it in our regional language, and now we are very strongly advocating a joint approach of the treating physician along with the transplant coordinator while speaking to families.
That's great, thank you. Sam, I'm going to come to you now, and just again, if you would introduce yourself and just give us a little flavour of the model of your approach and the system that you work under there.
Yeah, hi everyone. My name is Samsudin, or known as Sam. So I'm a donor coordinator from the National Organ Transplant Unit in Singapore, where we have what is known as the heart of opt-out system. So myself and my colleagues, we attend to all potential donor cases across the country because we are a small country. And similar to what Julie had mentioned, similar to the UK, our ideal model approach is collaborative, where we have the stakeholders such as the doctor, the nurse, and medical social workers present during end-of-life conversations.
Perfect, thank you. And then Vuyie.
Hi, my name is Vuyie. Everyone calls me Vuyie. I'm a transplant coordinator from Fortescue Hospital, which is based in Cape Town, South Africa. We have a bit of, like Pallavi, we haven't really defined everything, but at the moment we're more looking into a collaborative approach. Then there's the treating team who has a nurse, and then the doctor, and then will be the transplant coordinator, myself and my colleagues, and then we have our team as well, palliative care team. So the people is joining into the conversations. And if we don't have we don't have like an opt-in or opt-out system, but we're more like pushing people into the opt-in kind of direction.
Okay, great. I think that's really helpful to have a baseline for where we're making our comparisons as we go out through the rest of the conversation. So Cathy actually touched on something during her presentation around language and terminology and the importance of that, and some of the skills that we've seen from our specialist nurses and specialist requesters as they've been in front of grieving families, and the skill and expertise to agilely kind of navigate those conversations. But one of the things that has occurred to us, and we've heard a few times, is the importance of discussing death and dying. Now here in the UK, we've always been trained to be very clear in our language choices in that we talk about death and we talk about dying, as opposed to presenting it in a euphemistic way that could be misinterpreted, so language like they've passed on. So Julie, I'm going to start with you first. Just give us a little bit of a flavour really around why we do that, why it's important, and then again, we will come over to our Commonwealth colleagues for your opinions.
Yeah, no, absolutely, Phil. I think it's definitely really important that we use the clean language that Cathy has just been talking about as well. We know ourselves from meeting all the different donor families that really their cognitive processes are slowing down, and we're giving them so much information at that time. We need to be sure that they are clear and they understand what is being said. So we do advocate for using words such as death and dying as opposed to passed away, or just to make it quite clear that this is the situation that they're in.
Okay, great. And I think we have heard that some international, countries, some cultures may find that type of language quite direct, maybe even offensive. So I'm going to open it up to the floor. Sam, I'm going to come to you first. What sort of language do you use to describe actually death and dying when you're with families? Is it as perhaps direct and as pragmatic as we use, or do you take a different approach?
Yeah, I mean, if you ask me to summarize, in preference, it should be direct. I mean, at the end of the day, the terminology that we use during such times is very important because families can be confused, can be anxious, and the terms that we use are very important. So in situations where someone has died, we find it useful to not only be direct, but also probably the use of the time of death together with the terminologies is also crucial to further assure that there is no ambiguity that the person is dead. But we do acknowledge, especially during our trainings, we do acknowledge that while it's ideal to be direct, there is this barrier, which Cathy mentioned as well, personalized and so on, that people have to overcome sometimes when they have these conversations with families in having to describe someone as dying or died. So we find it useful through training to overcome those barriers by crossing those lines, by actually digging what's stopping us by saying that the person is dead. And of course, here in Singapore, I think we find it useful as well to be able to describe death in other languages, in our mother tongue languages especially, so that if we have to use it, we are able to use it confidently, without any ambiguity, and especially when certain family members don't speak the same language as the same person, same as the main spokesperson. But of course, apart from being direct so that there is no ambiguity, the timeliness or the empathetic use of these terms are also important, because no point being accurate through directness, but we are not being sensitive or it's brought up at the wrong time. So all of this space comes into play together.
Great. You make a really interesting point around where different languages, actual mother tongue, as you describe, is prevalent, and I think that's something that we'll probably possibly hear from all of you. Obviously, here in the UK, English is the predominant language. You've heard me butchering the Welsh language just a few moments ago, but very rarely do we conduct those conversations in Welsh. So it's an interesting complexity that I guess layers on top of how you approach your families. Vuyie, what's the South African position?
Well, currently with us, we've got quite a number of different languages in South Africa, I think about 50, I'm sure. But we lead with English, depending on the family and how they come across as well. But in the Black communities mostly, it's much easier to communicate with them in their own language. And there are some words that when you say, they're a bit harsh, like Sam was saying, because you have to try and make it in a longer sentence and try and explain it more. Because like other families, they will think that you're being sensitive, but we try and accommodate them in their own language. We've got quite multiple people that can actually be translators for us, and it's quite easy in English most of the time, but some families, they take it harshly. But we always have to make sure you mention the person is dead. It's not, instead of, like you said, no longer with us, because it might not come across as the true definition of what you actually want to achieve.
So you would advocate quite a direct use of language around death and dying. Okay, fantastic, thank you. And then Pallavi, what's the Indian position on this?
So I'll agree with Sam and so there is an emphasis in our training where we advocate usage of words like death and not brain death. Okay, you talk about brain death, but ultimately the fact that the person has died has to be conveyed in those many words. Not saying he or she is being maintained on a ventilator, artificially being maintained, or has lost all reflexes, because these are all very ambiguous terms. And in our context, not all our transplant coordinators are people with nursing backgrounds. We have a lot of coordinators who are people with a social work background or a psychology or a sociology background, and not necessarily trained to speak about hardcore medical stuff, even if they have all the knowledge. So we do tell our intensivists and neuros that please tell the family that your loved one has died, and the fact that all of these conversations have to be placed in the whole end-of-life context, where you've established relationship with the families, you've been having regular conversations with them, so that when it finally comes to giving them the news of death, you're able to do so honestly and directly. Perfect.
Great, thank you for that. So I'm going to move us on a little bit to another topic area that we've been discussing around timing of the donation approach, which part of the way that so if we focus on DBD donors particularly, and Julie, I'm going to start with you. Our best practice tells us that we should speak to the family about donation after the second set of tests. Just a brief explanation why before we start thinking about the comparisons.
Yeah, so that's absolutely right, Phil. So really best practice for us here in the United Kingdom is to have that conversation with families after the second set of brainstem death testing. And that's confirmatory set of tests. The first set of BSD testing, that would be the time of death, but that second set confirms that death has occurred. And that also, the families we offer quite often, they can come and witness that second set of tests. Ultimately, that allows for that family's acceptance of what has happened really, and that death has occurred before we would move on to what happens next. We want to make sure the family are understanding and accepting.
Yeah, and then I guess it's the what happens next is if the family agree, then we go ahead with donation. If they don't, then the ventilator eventually, after some discussion, is obviously removed, and the patient will undergo kind of end-of-life care, and they'll die with their family there. But we uncovered something quite interesting, Pallavi, when we were talking to you in preparation. It might not seem like we're fully prepared, but we are, honest. So we had a good discussion about this. And you uncovered something really interesting about the Indian position around what happens if the family say no to donation after the brainstem tests. Just enlighten us on that.
That's a bit of a tricky thing, because our law does not categorically state that if the family has, declined donation, that the ventilator can be switched off. So that clarity does not exist in the law, and so many physicians and medical people are wary of having this conversation. So you ask the family for donation, and the family says yes, great. But the family says no, and then they say we want a loved one back, we want the body back, and so that becomes a bit tricky, you know, dead for donation and not dead to be removed from the ventilator. So there needs to be better clarity around that. There are certain doctors who say that if the law tells me that if I perform both the set of tests and the person is dead, well, the person is dead for me, and with consultation with the family, I will go forward in finding ways to disconnect from the ventilator. But a lot of physicians say this needs to be clarified for us to be actively involved in this program. Yeah.
Okay, so it's a really interesting complexity, and I think we think that our approach in the UK can be quite challenging when we talk to donation or potential donor families. But what you're saying is that if the family agree to donation, then the law supports the removal of the ventilator for that to happen?
No, then it just happens automatically. The person is taken an AOT and retrieval starts, you know. So there is no conversation about removal of the ventilator, because then it becomes a donation case.
Of course. But if they don't support donation, the law doesn't support you removing the ventilator?
It doesn't articulate clearly.
Okay, so really challenging kind of position to put your specialist, your donation transplant coordinators in there. So yeah, thank you for sharing that. We found that absolutely fascinating during our discussions leading up to today. But again, picking up on some of the work that Cathy has presented around that line, that metaphorical line that everybody seems to have a kind of a moral compass as a specialist nurse about how far you push that family that might have given a knee-jerk no. And we wanted to understand from you how far you're prepared to go, or how far you train your staff to go, or what the expectation is of your teams. And Sam, I wanted to start with you in Singapore, because purportedly you have a hard, soft, get my language right. You've got a hard opt-out system. So that's right, yeah? I hope so. That's what I've prepared. Anyway, so you've got. So anyway, Singapore purportedly has a hard opt-out system. So theoretically, even if the family say no, if there's no registration, you could potentially go ahead. Is that the case, or how does that play out with you in Singapore?
Yeah, so Phil, I mean, using the words store, hard, or firm opt-out system, I think doesn't really do the justice, the complexities of the legislation and also the processes that's involved in the communication and so on. But essentially, yes, what it means is that in Singapore, when the Singaporean is certified dead, his or her wishes on the organ donor registry will be respected should he be a suitable, medically suitable to be a donor. But that does not mean that we completely ignore the family's concerns if they have any. So in most cases that we encounter, usually the stepping down of hope have been done early. The pro-prognosis, the various team members have been involved. So stepping down of hope have been done superbly, and the topic of organ donation, if it's applicable for that case, is brought up timely as part of a normal end-of-life conversation. It's essentially normalizing donation as part of one of the end-of-life choices. Okay. And we know that, you know, and I think from studies and I think from our various own respective experiences, we know that most families do not disagree with the benefits of donation, and that if you ask them themselves, they would consider themselves to be an organ donor, probably. But, you know, that decision is not that easy when you have to decide for a loved one, especially when most brain death cases are sudden or traumatic. I think Cathy also brought this up earlier on. When you put them in the position of decision making, somehow the legislation can help in that decision making, because it doesn't, the decision is not made by them, right? So in a way, when you respect the opt-out system, the organ donor registry, it helps to relieve some of that burden of decision making. Of course, when there is, I'm not saying that there is no or decline that the families come about, but when there is such a situation, I think the team respectfully explores what are the underlying reasons behind that decline. Essentially, whether is it what kind of lines, what kind of concerns do they have, and most of the times it's because of that uncertainty that I mentioned earlier on. or concerns with how the disease will look like after donation, whether will they be respected through the donation, whether is it in line to your religious faith and so on. So really to take some time and attention and really journey with the family respectfully in a respectful manner. And when these concerns are allayed, and you just refocus on the donor, how the donor was, what would he have wanted, and what kind of legacy that is leaving behind. The opt-out system actually helps to relieve some of the burden that several of us mentioned here. Yeah.
Okay, so I'm just going to push you a little bit harder on this one. If you've got an opt-in, so the patient has opted in on the organ donor register, but the family then disagree with it, it sounds like us in the UK, most families will support that. But if there are those few that say, actually, we don't want that to happen, do you still go ahead, or do you respect the family's wishes? Obviously, acknowledging that you will explore as far and trying to understand the rationale for why they wouldn't. But at the bottom line, would you still go ahead or not?
We will respect the donor's wishes in accordance to the organ donor registry.
Okay, interesting.
If I were to put the opposite to you, if a person had opted out during his lifetime, right?
Yeah.
But for some reason the families wants their loved one to be an organ donor, right? We will still respect the organ donor registry. That means the person will not be an organ donor simply because he opted out, even though the family wants the person to be an organ donor. So it's a balance of in a way respecting the person's wishes, through the organ donor registry.
Okay, that's great. Thank you. Vuyie, what's the position in South Africa?
We just purely depend on the family. If the family says yes, it's a go ahead. If the family says no, then we can't go beyond that. However, it does help when some families are aware that the person was registered to be an organ donor, no matter how old that registration is. If they say yes, and some have cards, because we've got the organ donor registry, but it's not a publicized thing. So if the family knows their wishes, then we go with that. However, in the case that some families are actually conflicted between one another, one would say yes and the others would say no, then that's when we take a step back, because the family have to agree amongst themselves what happens, because at the end of the day, with this great, wonderful thing that we want, we don't want the family to break up because of that good thing that's going to come out of this person's death. And so we just give them time, discuss it, and then come back to us. But at the end of the day, time also takes a lot of perspective into this. If they can't decide what to do between themselves, and we run out of time, we just say, okay, fine, we're not going to be actually pursuing the whole organ donation thing in respect of the family, no matter what the wishes of the deceased are. So we just step back. Okay. But some families, you find that mostly the older man is actually the one that is misinformed. They don't understand. They don't even know what this organ donation is. Some people have just never heard of it. And we have to try and explain that to them and make them understand, basically. But the time that this whole thing has to be explained is the worst time ever. So the one who has the information, is into organ donation, doesn't have the right in the family to make the decision. So it takes quite a long time to sway them into the right direction. But some cases turn out good, some we just end up losing, and we give up because of time and the misunderstanding, basically.
Okay. Okay. So again, it sounds like family have the kind of the authoritative weight, the final say. So is that something that you see also in India, Pallavi?
Really the same. It is the family's prerogative.
Okay.
We can only give them information, help them to take an informed choice. Like I said, if there is a strong dissent between family members, we will try to work with the family members who are keen to make the donation happen with the ones that are not. But we will step back if there is a very strong dissent between family members.
Okay. Okay, that's interesting. Vuyie actually just said something about consensus and about when you've got a family, perhaps even a big family, and that kind of brings us on to a topic that we were going to discuss about the decision makers and the number of people in the room. And again, Julie, part of our training is we've always kind of said, you know, try and just slim it down. If you enter an intensive care unit and you've got 20 family members in the room, slim it down to the key people. But that might not be the case in other cultures. But what's our position? Why do we do that? What's the rationale there for it?
So I think why we want the streamlined family there is we really want the nearest and dearest, and to establish the people that knew that person best, because these are really important conversations we're having with them. And actually it is laid out in our law as well, with our highest qualifying relationship and our nearest relative as well, that they are the people that we would want to be having these conversations with. I think as well, we know from like the COVID pandemic as well, some of our family rooms that we have, the space can be quite minimal, so really we can't have large volumes of people, just in a sort of capacity side of things as well. It can be really challenging though.
Yeah.
Yeah.
Yeah, so I think that's an important point. There's a practical side of it in that the rooms are always tiny. They're always about 500 degrees as well. But also the legal side of these things is that we know who we should be speaking to as it's laid out in law. Pallavi, if you're met with a big family, or one of your team is met by a big family, do you take a similar approach to the UK and try and slim that down, or are you trying to speak to everybody? I know that different cultures take a different approach, and there might be kind of some rituals or people involved that need to be there as part of the family decision-making process. What's your take there?
So that's definitely a challenge in our country. Usually these are joint families, and we have an additional problem. It's not always just the families. Sometimes village heads and village elders are part of the process, you know, it's what we call panchayat. So sometimes the family is actually not there. Very often in the region that I work, in the neighboring state called Haryana, women are not allowed to come out of the house. So there could be a husband would have died, and I don't have the family, the wife to speak to. She's really not there in the picture. So we have no option but to work with the extended family and also the villagers sometimes to get to the right person, you know. So it is definitely a challenge, and I don't know if we can create situations like Julie mentioned, where we say only some people will enter the, only the immediate relatives will enter, because sometimes the decision makers perhaps may not be immediate blood relatives. So you have to respect that in our context and try to.
Yeah. So I'm interested in that in terms of then if you've got, so how is there a decision reached? Is it a consensus, or will somebody naturally take the lead and say, this is what we're doing?
A combination of both. In certain families, it would be a consensus. They say, oh, I can't decide, the village elder will decide or the family elder will decide. In certain cases, I remember a family, while the rest of the extended family was just not interested, both the sons, young people, they were, I think, in their 20s, said we want to go ahead and we will bring our mom on board. She had not come to the hospital. So it's really a combination of both, and they were able to take that strong decision and decide this is what we want to do as a family. So, yeah.
Okay. Vuyie, I see you nodding along with this. It's something that I guess there must be, are you nodding along because there's parallels that you see in South Africa?
Yes, I find it very interesting because we mainly concentrate, like Julie was saying, the immediate family. I mean, the rooms are small and COVID doesn't want many people in the space. So we stick directly to the blood relatives. But as you know, South Africa is huge, and we've got a lot of, because we do accept foreigners as well if they want to donate. But you find that the one says, this is my brother, this is my uncle, only to find out they're not even related. They're just friends, or they come from the same village. Then they come in front of us, then they behave and then pretend to be family. But one thing always strikes me is that when they all agree to this and you put the piece of paper in front of them, they have to sign, then that's when the truth comes out. Actually, I can't sign. Let's wait for the actual brother. Oh, let's wait for the sister. I'm just a friend. I'm a family friend. We've grew up together, such things. But we've always toned it down to immediate family, the parents, partner, the siblings, and the children, if they're in the rightful age to consent, because they have to all agree to this whole thing. So it makes it easy in that way. We just put a paper in front of them and they will all back down.
Okay. I don't know if you can hear it, Vuyie, but our audience has got a knowing chuckle about them. They can relate to what you're saying about when you put pen to paper, the truth comes out. So yeah, very good. Sam, how about with you? Do you have similar experiences to our other colleagues there?
Very, very different and very interesting to hear the difficulties and to sort of put things into perspective for the situation in Singapore as well. But I guess ideally in Singapore as well, when we have such conversations, it's always with the few key people or those close to the patient. But we also recognize that every family is different. Some may request for larger family groups to be present, or maybe some powerful support person like a religious leader to be around as well, because it is important to them. So we have to be aware that sometimes, these are important to the family. And sometimes when we are in a room full of people, we also realize that, those people who are the main spokesperson, the ones that are talking the most or the loudest, you may not necessarily be the decision makers. So usually the quiet one in the corner who's nodding is actually the one, the so-called key leader in the group. And also sometimes, I don't know, close families may want everyone to be together so that everyone's on the same page or something like that. Yeah, so ideally, lesser the better, but every family is different and we try to cater. And of course, like what you said, COVID complicated things during the pandemic. Yeah,
exactly. So I'm just going to move on to a kind of a different topic area around not just with regard to the number of people in the room, but also the religion that might prevail in that conversation. So in the UK, Julie, we don't necessarily train specifics on each religion because there are so many, and different people's devotion to that religion will differ. My relationship with Christianity might be different to yours, and you can just multiply that by a million across all the religions. So why don't we do that, and what approach do we take?
I think that's the thing, Phil. I don't think we're expected to be experts in every single religion. As you say, there's so many differences, and I think it's important that we respect that. But ultimately, I think what we need to do and what we do strive to do is actually find out from that family what is important to them, and then we best support that whatever way possible. But we took that humble approach as such to really get into the bottom of what is important to that family and to their loved one as well.
Yeah, exactly. So being guided by that family, what they want, what they need. So again, across your countries, there'll be some similar religions that we're familiar with here, but there may be some different as well. Do you, when you're training your staff, do you take an approach of training on specific religions, giving your staff an in-depth knowledge? Is that something that we might want to consider doing here, or is it? I don't know what the alternative is. What is your approach? Pallavi, let's start with you.
So no, I agree with what Julie said, and then it is difficult to find. But we've had, in the past, we've had religious conclaves. We've invited religious leaders from various religions in the country to understand what they are saying. So help our transplant coordinators see what, because to be honest, no religion has anything written about organ donation. It could only really be what the religious leaders are espousing. So really coming down to what Julie says, what really means for that family, giving them information, but just being sensitive to understand which religion they come from. That's part of the preparation when you're approaching the family. It perhaps would help, is what we tell the transplant coordinators, but no specific training with individuals.
Okay, thank you. Sam, is that similar for you?
Yeah, largely the same. I think our training does not actually train on the specifics of religion, but rather, similarly to how to cross those barriers, those lines. I think especially in Singapore, there is this tendency to be afraid to talk about religion with the fear of offending the other person's religion. But I think most of our training focus on how to understand what does the vision or the mission mean in their religion by asking questions, exploring, while also respecting that we just want to know and understand better. Because just to give a little bit context as well, the organization law in Singapore only became opt-out also through consultations with religious groups and so on. So I would say that most religious groups support organ donation in Singapore. So while we don't train the necessary specifics into religious topics and so on, we explore how to understand what's the concerns. If they're using religious concerns, is it really truly religious, or is it because they are worried of things like whether the disease is being respected? Because no matter whatever the religion is, all organ donors are being respected.
Yeah, fantastic. And Vuyie, what's your...
Similar to what everyone else is saying, we don't get necessarily trained on each religion. It's the family leads you most of the time, because when you come, it depends how they come across to you, because if you assume, for instance, in South Africa, most people are Christians, right? We do have a lot of other religions, but when you meet someone, unless you speak to them and how they speak to you, that helps guide you how to carry on with the whole conversation. But we always treat them the same with the utmost respect, and if they actually voice it, that this is their religion, at least it gives you an idea, because some families, they will actually say, no, our religion is like this, and this is how we do things. Then it takes you to a different direction, and then you change the whole conversation into a much more respectful manner to accommodate them in their religion.
Great, perfect. And Sam, actually, you raised a point around consultation and engagement, and I think that's something that we feel like we've done very well in the UK when it came to changing to opt-out systems across each of the nations that have implemented them, is that we went to many of the big religions, some of whom had been quite reticent and reluctant to engage around organ donation, and just kind of ask them, what do you need from us? How can we help? How can we show you that your religion is compatible with organ donation? Or what do we need to know more to provide you with that assurance? So I think you're absolutely right. There's the micro level with the family, on the face-to-face, respect them, take that humble approach that we've described. But there's a bigger macro piece around engagement and trust and that sort of thing with those religions. And I think it's something we feel like we've done pretty well in the UK.
I don't know about, sorry.
Go ahead.
Others, but in my experience, I've had very few families who've really brought in religion as a reason to not to donate. They have more real concerns, and I don't know. It hasn't been such a huge challenge for me. I don't know in terms of percentage. Perhaps 15% of the families would have brought up religion as a reason to know. It's either just it's either lack of trust in the system, or they need to know if there's a proper allocation system, or how would the body look post retrieval, or the delay in cremation. And those are the concerns that usually people bring up.
Yeah, and I think that's something that the specialist nurses in the room will certainly see, that where a family might refuse on religious or cultural grounds, actually the underlying factor is perhaps what you've just described around healthcare mistrust or disfigurement, and we saw that again from what Cathy was describing. So yeah, you're absolutely right there. Okay, what I'm going to do is I'm going to start to do a little bit of a wrap-up on what we've been talking about here on the panel discussion. I'm going to thank my panellists. I appreciate for some of you it's quite late in the day, so I appreciate that, but if you could stay with us a little bit longer, we're going to have a question and answer session in a few minutes. But I'm going to introduce Karen Otti. Karen is a specialist requester based in the Midlands team. She's been working with Dale and Dale Gardner, Mr. Dale Gardner, Dr. Dale Gardner, and myself on a piece of work that looks at how closely families stick to the organ donation registration made by their loved one. And we've got some interesting findings, so I'll hand over to Karen. Thank you.
Thanks, Phil. Hi, everyone. So I'm conscious of time, so I'm just going to dive straight in. So as Phil mentioned, we conducted a prospective 3-month study looking at how closely families support consent of the donor that's been given by the ODR, or do they modify that consent in some way? So So our focus was, well, we know that the HCA acknowledges that a recorded decision on the ODR or an opt-in is considered consent, and that families have no legal right to veto that consent decision. However, what we didn't know is how often families modify or overrule this. Most importantly, we were interested in partial overrides, where the family agreed to support their loved one's donation decision but place additional restrictions on which organs and tissues that they're willing to donate. So we had hoped to provide an understanding of the importance and the impact that this has on transplantation rates. So first of all, we needed to look at what constituted a family, and we realised that the definition of family is quite broad. So for the purpose of our evaluation, we used the Human Tissue Authority's qualifying relationships, whereby family encompasses those in a qualifying relationship to the person immediately before death and may include their family members, friends of long standing, and those familiar with the faith and beliefs of the potential donor. And I'm sure that most of you here do know that for Scotland, it's a little bit different in that the hierarchy of family members is in a different order, and that nominated representatives aren't recognised. So we know that since Wales introduced their deemed consent law a few years ago now, that the ODR needed to be adapted to incorporate opt-outs as well as opt-in decisions. So last year, 41% of the UK population had recorded an opt-in decision, and an opt-out decision was recorded for 3.5% of the population. So when the specialist nurse accesses the ODR, we're presented with one of three options: an opt-in all organs and tissues, an opt-in selected organs and tissues, and the opt-out. So for those who opt in can specify which organs they would consider donating, but this is dependent on which platform they choose to use when they sign up. The platforms include the DVLA, the ODR website, the NHS app, the GP service, and of course the Boots Chemist loyalty card. Some of these, however, only allow for the all organs and tissues to be chosen, and it's only the NHS app and website that allows for the full option of the individual to select the organs and to also record an opt-out. We already knew that the opt-in registration are supported by families in the UK for 90% of the time. However, whilst 90% is impressive, it does come with two major caveats. Firstly, it's not unlawful for the families to oppose an opt-in decision. Permissive law allows donation to proceed, but it doesn't mandate that it has to. In the UK, this accounts for roughly 100 donors, which is 10% of all of our opt-in approaches. And secondly, families can modify that registration, and this reduces the number of organs and tissues that are available for transplantation. So we included England and Wales and Northern Ireland. Apologies to Scotland. We did exclude you because of the legislation differences, but this was done with the support of the regional managers and the RCLODs. And it is hoped that we are able to support a similar investigation for them in the future. So, how did we do it? It involved direct comparison between the recorded ODR entry and a formal consent form, and in some cases the narrative on donor path was also examined for each donor over a consecutive 3-month period. The investigation identified the number of fully supported consents, where the ODR registration and consent form matched, partial opt-in overrides, where the family supported donation, but they reduced the number of organs and tissues that they were willing to offer, and finally, where family requested to consent for more than the recorded ODR entry. However, we didn't find any of those. So, as I mentioned on the previous slide, the difference in Scotland compared to the rest of the UK made direct comparison challenging, so they were excluded, such as the family hierarchy and the Human Tissue Acts that we work under. Verbal opt-in and verbal opt-outs were excluded, for obvious reasons. If consent's given or denied by a family for an organ not stated on the ODR, these were also excluded. Where an organ or tissue was considered unsuitable by the specialist nurse prior to consent, but consented for by the potential donor, then these were also excluded because obviously, as you know, we are trained only to gain consent for eligible organs. And finally, because the focus of our investigation was to look more closely at how families modified an ODR registration, deemed consent was also excluded. So our results showed that over this 3-month period, the consent rate in the UK was 69%. And for donors who recorded an ODR registration, that was 93%. No one who registered an opt-out had their consent overridden by family. And of those 205 opt-ins, an alarming 85 had restrictions placed by families. And of those 85 restrictions, 16 were full overrides, and an alarmingly 69 were consents where the family modified the ODR registration in some way. So that's a massive 69 occasions, which equates to 166 organs and tissues that the donor registered to donate on the ODR, and which were considered suitable by the specialist nurse, but they weren't offered. So this equates to 35%. I'm just going to have a drink of water. So this was based on a 3-month time frame. So if we scale that up to a full 12 months, that represents a massive 664 lost organs and tissues, with an additional number of organs and tissues that are lost from the full ODR overrides, then that number's much higher. So current literature on why families modify donor registration is quite limited and tends to focus on why families refuse donation completely. So we propose a number of theories why some families who support donation may feel unable to do so fully. So if we talk about eyes and hearts, in the UK there's an ongoing shortage of corneal donors, enough to have a real impact on those awaiting for transplant. We know that some organs and tissues, specifically the heart and the eyes, carry with them emotional connections. For instance, the eyes are often cited as being the windows to the soul, and it's a well-documented ick factor as well. The very idea of removing the eye is just too much for families to take, or some families to take. And the heart symbolises love and is also found to be commonly restricted. However, we found that no similar restrictions were placed on the liver, the lungs and the kidneys. So here's a slide you probably didn't expect to see. So rather surprisingly, our findings highlighted that families frequently decline the pancreas more readily than any other abdominal organ. One possible reason for this is lack of knowledge about what it does or how a potential recipient may benefit from a transplant. In 2019, the charity Pancreatic Cancer Action highlighted that 40% of people had no knowledge of its function, 43% didn't know where it was in the body, and 44%, when shown an anatomical model, said it was a penis. So the charity have since instigated a campaign to improve the knowledge of the pancreas, and they've created the hashtag #PancreasNotPenis. So, as I previously mentioned, no families restricted the donation of the liver, the lungs or the kidneys. Our aim was to evaluate possible reasons why families may want to restrict ODR registrations. So the conversations we have, as Cathy's mentioned and everybody else has mentioned, are complex, they're nuanced, and they're conducted at a time of acute bereavement, which is likely to influence the reasons why families place restrictions on some organs and tissues and not others. In the UK, after a family has agreed to support donation, there's a requirement that they answer a medical and social history questionnaire called a MASH, and this consists of 78 questions. And it usually happens prior to the consent form, which is a further 44 questions. So we propose that one reason why families restrict consent may be related to list fatigue. And this is where less thoughtful answers of questions are given near the end of a questionnaire, or the individuals prematurely terminate their participation. Quite often we can see without the families actually telling us that they've had enough. And as we know, our donor families are tired, they're exhausted, leading up to the consent process. One possible contributing factor that's seldom discussed are the notions of compromise and fair play. Benevolence is a central motivating factor for nurses' decision-making, and our aim is to do good when responding to a person's vulnerability. So we may compromise when a family is showing visible signs of emotional distress, physical and emotional fatigue, and that they've simply had enough. It may feel perfectly reasonable or even fair when a family have been through so much and are giving so much to accept their decision to donate some but not all organs. I know I do that quite often. As Cathy mentioned, there is a line that we are willing to cross or not to cross, but we all have different lines in different places. And it's just to note here that beneficence, which is the principle that a nurse's actions should promote good, should not be confused with benevolence, which is the act to benefit others or the disposition to do good. So we have that internal conflict, don't we, whereby we want a good outcome, but we also want to feel good about how we've been with the family, and we want to leave the room feeling good. So we had to look at the limitations of our evaluation. So our data was gathered over a 3-month period, and while the sample size may indicate trends, obviously further research over a longer period is necessary for validation. Again, the global pandemic may have influenced or impacted upon our results, and our investigation didn't address factors that we already know influence families and consent rates overall in the UK, as this has already been published elsewhere. The data analysis required a manual search of 205 individual cases, and some data sets weren't explored due to inaccuracies and missing information. The data may provide strategies to better support families at the time of donation, but a future study may want to include the mode of entry onto the ODR, for instance, the DVLA or website, for example, versus consent rates. Following our evaluation, we've highlighted some recommendations, such as other countries, like those that have joined us today, may want to publish their own data for the number of times families modify recorded opt-in on the ODR. Future studies should explore factors such as relationships to donors, the donor's age, the consenting family member's age, the gender of the donor and their ethnicity and the culture. The UK Potential Donor Audit, which is what we call a PDA, could be adapted and modified to incorporate this information in a similar way that it captures the recorded decisions and why families refuse donation completely. Ongoing marketing strategies should highlight the importance of donating eyes, hearts and pancreas, not penis. Public awareness of the pancreas should be promoted, and the specialist nurses, explanation of the importance of the pancreas maybe at the time of consent could be an additional focus for training. The specialist nurses training focuses really on our donation approach, with an emphasis on consent to proceed, but the study highlighted that equal attention really should be given or directed to supporting us as specialist nurses to improve the outcome of consent so as not to offer a compromise at all. However, this does remain somewhat controversial. Excuse me. This would ensure that donors' explicit consent is adhered to as closely as possible. There is evidence that society supports prioritising the donor's view alone and above all else, as identified in several public consultations that happened before we moved to deemed consent. For example, in England, when asked, do you think someone's family should be able to decide if their organs are donated if it is different to the decision that was made when they were alive? 6% stated yes, 28% said sometimes, and Significantly high number, 66% of people said no, the family should not be allowed to modify or change the donation decision. So these levels of support were similar in Northern Ireland and Wales. So, if you can take anything away today, please remember that a huge 35% of our donor families modify their ODR registration, their loved one's ODR registration. That's a massive 600, well, over 600 plus transplants a year that do not happen as a result. Thank you.
Thank you very much, Karen. And I think that hashtag pancreas not penis should really be trending, hopefully later on today. Everyone please tweet. So if I can ask Cathy and Julie to join us on stage, and hopefully from the back, if we can have some roaming mics, and if we can just get our international panel back up. I would encourage people to step up to the mics and ask questions to the panel, and there's lots and lots of questions on the app already. So we'll see if we can try and have everyone seated. If not, we'll just use the lectern. So dark out there, I can't even see if people are standing next to the mic. So I'm going to start with one of the questions from the app. So one of the questions I think is directed to you, Cathy, but it'd be really interesting to see what the rest of the panel thinks. That given the fall in consent rates, so I guess this is looking at the UK, and the opt-out is not working, do you think we should be moving to a harder opt-out? And how do you think that would be received by families, but also by the specialist nurses?
I don't think it will get away from the situation we're faced in, and that is that each situation is unique. That family are grieving, they're suffering a loss. I'm not sure that moving to a hard opt-out actually would make much difference. And where we've seen this happen in other countries, they've actually pulled it because it hasn't worked. It hasn't offered what they thought it might. So I think it's more important to focus on public awareness strategies that look at the families having that conversation, share your decision, talk to your loved ones about it in life. Because even with a soft opt-in law, if the families don't know what their loved one would have wanted, it's quite tricky. We are seeing the law working where it's leveraged, where people use the law. So if the legislation's mentioned in that situation, for some families, it will influence the choice and decision they make at that time. But I'm not convinced, if that was an option to move to a hard opt-out system, that would work for us in England or the wider UK, to be honest. I don't know what the rest of the panel think.
I completely agree, Cathy. I think it's more important for people to have that awareness of what their loved one would have wanted and what their decision was, and encourage that conversation as opposed to putting, a hard opt-out system in place.
Yeah, I would agree, to be fair, Cathy. I think it's all right having the law behind you, but saying it and using it in that consent approach is quite difficult at times. Not all the time, but at times. And I think if we were to lead with the law, which we probably would need to if it was a hard opt-out, that would be really tricky.
And just to our international panel, I was going to actually say that pretty much fits in with what Sam was saying about Singapore, that what's written on paper is not actually what happens in practice. But for Pallavi and Vuyie, would you agree that moving to a hard kind of consent system, whether it's opt-in or opt-out, really wouldn't work for your countries?
Most definitely not for India. We're still way behind. I think it's very premature for us to be thinking also of an opt-out system. And I agree with the panelists sitting on the stage. We have to work harder on creating awareness and creating robust systems, creating a greater trust amongst people in this whole process, and creating greater positivity around organ donation. Those should be really our thrust areas. In India, I think we need to cover some ground before we can even begin conversations around opt-out, leave alone hard opt-out.
Yes, I completely agree with everyone else. I mean, like Pallavi said, we're also in South Africa, we're still quite far with a lot of things. And because of our different cultures and religions, it would be something, it would cause a lot of chaos with organ donation as a whole. And I think it would also shrink our pool, our organ donor pool as well, because I mean, who's going to be signing if we're forcing everything? And at the end of the day, we also want to teach the public, because for tomorrow, you see, so more public awarenesses, education sessions, public speaking. It's what would help at this moment.
Excellent. I mean, you mentioned kind of religion and cultures, and we'll come on to that. There's lots of questions on that, but I'll just move over to Della.
Hi, good afternoon. I'm always standing, and this is for my international panel, I think I have to stand here in defense of my community, which is the black community, because we often hear in the UK that we don't come forward as donors. And I've listened to you. I come from Nigeria, and for me, organ donation is not a problem for me. I was born here. It's a no-brainer. But we've got a big chunk of our population that come from countries like Nigeria, where we don't have an organ donation list. You come here, it's a foreign language. What is organ donation? They've never heard about it. So how do we change those ingrained mindsets that are from that community where organ donation is a foreign language? And we're asking them to come and, we don't even talk about death, let alone organ donation. So what advice can you have? And what we've done a lot of work within our communities to break down those barriers and to change those mindsets. But when you don't come from a country where organ donation is a practice, what do we do?
Okay, can I just say, speaking and coming from a black community myself, where I grew up, which is a township, people still ask me until this day, what is it that you do exactly? I have to explain it to different faces every other day, right? But from the point of what do we do, my main approach is approach the leaders. We've got traditional leaders in black communities in South Africa as well, and they are the ones who mostly the people will listen to. They regard them as the higher and most than anyone else. So if you approach them, maybe it would make a difference if the whole information that you have comes from them. They have to first understand what is organ donation, how does it go about, who's benefiting and all of that. And most importantly, what I find is that us mostly as black people, we don't go back to the communities to say, hey, I got a kidney, hey, I got a heart that was donated to me by someone that is actually passed on. So we don't feed back to the communities. Everyone knows that someone is sick, but how did you get help? How did you become better? So if we, as the black people, would go back to give back to the communities, teach them as someone that has been in those shoes, and mostly work very closely with the leaders in the communities, and maybe it would make a difference to some people. So, and that's the whole point. We're trying to make a difference, and a little bit can go a long way as well.
Thank you, Vuyie. We have another question from the floor.
Hi everyone, I'm Bishra Riaz from Kidney Research UK. Many people might know me. I work with the ethnic minority communities on organ donation, South Asian communities, the predominantly Muslim, Sikh and Hindu in Glasgow and Edinburgh. What I've seen with the work that we've been doing over the past 9-10 years with the peer educator model is using volunteers from the community, working with the community, and engagement we have. But yes, we work with the community members, but then we get to that stage when we get to the end of life and then the decision can be overruled by family members. Where I see the biggest gap is there needs to be a network where we have faith leaders, because we see that the biggest myths, misconceptions and barriers we have is a faith issue. More the fact is, does our faith allow organ donation? It can be a cultural issue, yes, it can go back to India, Pakistan, Africa, But the biggest issue is faith. Where does our faith allow this? So I know the work that I've been doing with the faith leaders within Glasgow and Edinburgh, that's really brought on a lot of confidence within the community. So we've worked with Scottish Government, organ donation, and on the websites and things. But again, it's only, you know, a small pinch, shall we say. We need to work in a global. So the same issue in Glasgow is the same issue in London. So there needs to be a network, a connection where we've got recognised faith leaders who talk about organ donation within the community, because, you know, there are faith leaders, but not all are versed on organ donation. So we need to make sure we're reaching out to the right faith leader and we're reaching out to the right people. So I think it's about being able to sit down and working out what's the best way to tackle this, because there's pockets of work that's going on, like the Hindu Jain community down south, the work that we're doing in Scotland, but we need to work in unity so we can overcome this barrier, because this is an ongoing trend and we really need to make sure that we can try and make some changes so we're not here again in 5 years' time talking about the same thing.
Thank you for that. I mean, it's there's a few questions on the app as well about certainly the case that was mentioned and the Muslim community and just approaching faith leaders. And what do you think about that as an approach? Because I mean, as just has been mentioned, it depends on which faith leaders you speak to, and it's not a case that people agree or disagree with organ donation. It may just be that they just don't have enough knowledge about organ donation. And there's also a question about kind of what kind of training nurses have in with regards to those kind of cultural sensitivities and things. So do you think there's more work that can be done with regards to that?
Absolutely. In terms of training, as we've explained earlier, we do adopt a very humble approach about what matters most to that family, so a very curious approach. It's very hard to be trained and affluent in every faith or religion that we come across. But from our guest speaker that came and spoke just now, it's really clear that as a group, as an organisation, NHSBT is far stronger with faith leaders in the community that are willing to support and help us with that work. So I think in isolation, we wouldn't be able to achieve it without the support and help that we get from people like Cathy Patel's team and the volunteers that are out there and the ambassadors. We really do depend on people. And I think as opposed to somebody like me working in that community and trying to profess my faith and my beliefs, it's far stronger coming from somebody within people's populations that talk to one another, that understand it in more detail. With all the training in the world, I would not understand everybody's faith and religion as sensitively or as thoroughly as I need to. And it's so nuanced, even understanding my own Catholic religion can be different for Karen, who may also be a Catholic person. So I think a curious mindset, very humble approach, and being really caring about what matters to you right now, what mattered to your loved one. Tell me, how can I help you? Yeah, rather than profess we know. Yeah, but definitely more education needs to go on in the community, and it was quite interesting to hear. And we hear it ourselves in our role. People don't fully understand about organ donation and what we do. They don't understand the law change fully either. They think they do, but there's a lot of myths and misconceptions. We hear quite often, you can take it anyway, you can just take it. No, we can't actually just take it. We wouldn't just take it. So there are myths and misconceptions that need addressing along the way. Yeah.
Before I go to the next question from the floor, just to the international panel, I mean, obviously, you know, India, South Africa, Singapore are very diverse countries as well. So do you do much work with faith leaders, community leaders, various kind of ethnic groups, and what's your kind of experience of that been?
So beautifully she's put it, and I think that really is the essence of, I think, no matter which country we come to, we cannot speak to every faith leader. Even within a particular religion, you may have spoken to certain faith leaders who will endorse it, and then there'll be certain who will not. While you continue to do that work, but that's not what is going to impact individual family decisions, and we really have to go back to that family and work with that family, you know, like she said, to understand what is important to them, and have we given them all the information that they needed and all the support that they needed through that grief process to help them take the decision that's best for them. That is, I think, where our energies really need to be. Why? Great to do work with faith leaders. I mean, I'm not saying it's either or, but I think working with families and helping them understand that, you know, they are in this very unique position to take a decision, you know, that can impact so many lives, and what is the information and support they need to take that decision is what we need to invest our energies in. Yeah.
Just a comment, in South Africa, just to give like two different separate answers for the same question. So in terms of ongoing public awareness, the faith leaders, they would actually be useful because through them, then whoever believes in their faith, they would listen best to their leader. But in terms when someone is actually now, is dead now, there are those families that would be like, they're there, they are the decision makers, they're happy to do it, but then you find some of them saying, I need to call my pastor, I need to call my imam, I need to consult. They basically need to consult their faith leader because they don't actually understand their own faith, how it is when it comes to organ donation. So we have to actually, we understand and we support them in that way, and we respect their faith completely. But some cases you find that the faith leader doesn't endorse organ donation, and it's their own personal view. And now it conflicts with the family because the family do endorse it, but now the faith leader doesn't, and they won't necessarily say my personal view is. Sometimes they would just mix it along with the conversation, and then it confuses the whole thing. Then once the whole conversation is confused, then organ donation is down the drain. It doesn't happen. So it works in yes, and then in some cases it doesn't work.
Okay, Harps has been waiting very patiently.
Thank you. Hi, I'm Harps from the Midlands. I think just finishing off the faith leaders, we find sometimes, especially in the Midlands, the family are positive, and the faith leader comes in, takes them away, and they've changed their mind totally. And I think we've had that quite a few times. Just going into my question, probably more to our specialist requester, do we use any specific targeted approaches, for example, to Asian families? And I'm looking at more direct approaches, using quotes like, if you're refusing, would you accept an organ if you needed one? And I know, Karen, you've been in a situation with a Sikh family once where you used a very direct approach.
Yes, I have. A couple of times, actually. Once it worked really well, and another time it really didn't work well. I had to sneak out the back door. But on the occasion that it did work really well, yeah, I did actually say those words which, and for me, like Cathy mentioned about the line earlier, I didn't think that I would push my line that far, but I did hear myself saying the words, if things were switched and we could save your loved one with a transplant, would you be in a position to accept? And I didn't know what was going to happen. I said them anyway, and to be fair, it did flip the decision from a we're not sure to a yes. So, yes, but I think every SR is different, every SNOD's different, and it's how comfortable you are. And I may have said it at that point, but I may not say it in a different family conversation. It depends on what kind of rapport I've got with the family.
Thank you.
So.
I do remember many years ago, I think the Behavioural Insights team did some work with NHSBT where they had the different messages. I think it was when you were filling your driving licence and which message kind of resonated the most. And if I'm right, I think it was that slightly more hard-hitting. Would you accept an organ if you needed one? And if so, consider donating. So,
just to add to that, I think we need to be so much more braver like that and really have targeted approaches, for example, to Asian families, and not be too scared and just take that risk.
Excellent, thank you.
Can I ask a question? So I'm Jay Patel. I'm a donor family. There are a couple of other donor families in this audience. I've sat here and I did admittedly go out for a bit, but I've not heard any of you talk about using donor families. I lost a 3.5-year-old boy. I gladly, me and my wife gladly donated his organs without being asked. But what I haven't heard you is saying, leveraging people like me or Lisa and others in this audience to say, when you're having these discussions, like, I happily stand on this stage and talk about my son till I go blue in the face, because I'm proud of the decision we made and the life that he gave back. And and what frustrates me when I'm sitting there is that there's none of you guys have said donor families should step up of all ethnicities and actually be used to promote the values. I often talk about two things. One, the actual transplant, what I witnessed after Ari came back from surgery. There was no butchery. There was no such thing as butchery. I also talk about the fact that we were given always the option to say no. It was fact after fact after fact, and we got the option to say no. I'll be honest with you guys, I'm the only, I don't know, Hindu, Asian, whatever you want to call me, British person that talks about this. And to hear it from a parent of a young child where we consented is actually quite powerful. So what I'm saying to all of you guys is, why don't we use these stories to promote where people are happy and willing to talk about it? Yeah? To promote the fact that life after death is actually a positive thing, and what it's given to Sina and I as parents. So I don't know if that's done actively. I know that I'll go to any stage and talk, but is that true internationally or of what you guys are witnessing? Would that help?
Yeah, it absolutely would help, and I recall hearing about Ari, and I really am sorry for your loss and really respect you coming up here and sharing your views. And I perhaps didn't mention in my presentation, and I should have, the framework for the deemed consent was taken to the donor family care group, and there were a few parents on that call, and the very special position was taken from one of the parents that kindly shared to me that mattered to me, that was important. When I heard the specialist nurse say that I was in a very special position, that's when I knew. So I have taken that forward. And also I remember yourself talking to me, and it really resonated that we're talking here about a law and legislation. Why don't you just talk about Max and Kira, because they're the people that have put this law forward. So whilst...
Max's mum is over there.
Hello. So whilst it's probably come across that way, and I can only apologise, we genuinely do value what you say and hear, and those are my two little snippets that I can share with you. But we do need people like you that don't feel it was like being butchered, that it was the most amazing legacy to leave. We do need people like you, because people aren't listening to people like me, because I haven't been there, I haven't done it, I haven't donated my child's organs, and I hope I never have to. But people like you are so unique and special, so thank you.
Thank you. Have we got time? Yeah.
Very short, yeah.
Oh, right, it's fine.
You sure?
Yeah.
I just want to squeeze in one final question.
Yeah. Thank you. I'm Dr. Tara Mane. I'm clinical lead in organ donation at Northeast and Hartlepool NHS Trust. I'm Asian in origin, of course, but my comment is a general comment, not particularly about any race or any religion. I feel when any person donates anything, for example, it could be somebody is running in a race and raising some money or donating something, there is a big news, and it comes in a trust website, it will come in the paper that he has donated 1,000 quids or whatever, he has raised so much money, and there is a lot of publicity or appreciation. But when somebody is giving their organs, their life, it's a gift of life, that's what we say, it is not recognized that well. There is not much appreciation families or the people they get. That's what I have realized when I'm working as a clod. So there is not much appreciation. So we can do definitely a little bit better in that aspect. And second thing, as Mr. Patel said, that we can use those families, their experience who had donated organs, their loved ones had donated organs, we can use them effectively for all communities. Thank you.
Well, that actually is pretty much end of our session, and I think there's a whole number of questions which we've not been able to address. But I mean, as we anticipated, it's been a really stimulating session. I'd like to thank all our speakers today, and we'd like to thank all of our international guests for sharing your experience and expertise. And hopefully, there's a lot that we've been able to learn from you, and vice versa. And I'd like to thank all of you for attending, for contributing, and for asking us the questions. Thank you.
Yeah, awesome.